Hi, I'm Dr. Sridhar. In this video today, we'll be looking at a hot topic, which is the revision from the American Academy of Pediatrics for the neonatal jaundice guidelines. It's very important that all of us are familiar with these changes. I'll try to cover all the aspects as far as we can. So this is the publication, and you can access it online. The clinical practice guideline revision for the management of hyperbilirubinemia in babies above 35 weeks, at or above 35 weeks. So it's a significant revision from the 2004 guideline. You can review my earlier lecture on the approach to neonatal jaundice. I will share a link below this video as well. It covers the most important parts of the earlier guideline. So the basics of the management, the principles or the approach to management stays the same, but we do have significant revisions or improvements or clarifications. So we'll focus mainly on the changes and a quick overview on the overall guideline as well. We will review the guideline as it's presented in the summary, and the first section is dealing with prevention of hyperbilirubinemia associated with isoimmune hemolytic disease. So as we know, the most common reason for isoimmune hemolytic disease is Rh negative mother with the Rh positive baby. ABO incompatibility is common, but it's not as severe in most of the cases, and it's difficult to predict which baby will have. So if you have a family history and you have a setting, you have to be more careful. There is no specific screening needed unless a baby is noted to have early jaundice. We'll discuss later. So prevention of hyperbilirubinemia begins in the pregnancy by recognizing and treating women who are at risk of developing antibodies to the red cell antigens, which can lead to hemolytic disease in the newborn. So we also call it as isoimmune hemolytic disease. If the maternal antibody screen is positive or unknown, because the mother did not have prenatal antibody screening, the infant should have a direct antiglobulin or DAT test. The infant's blood type should be determined as soon as possible, so we can categorize the risk of jaundice or the pathological jaundice having rising fast in the baby. So we should do this on either cord or peripheral blood. So there is a nice flow diagram that you can refer to. So the starting point is basically all the newborns, and then you review whether there is maternal antibody screen done or not. If it is done, you look at whether it is positive, and if it is negative, you can follow the guidelines as for any other baby. If the antibody screen is positive, or if the maternal screen was not done, the newborn baby should have the Coombs test as we discussed earlier, and the blood type should be done as soon as possible. If the infant is DAT positive, then we have to go to the high risk. If it is negative, then it goes to a normal management. So even if the baby is DAT positive, you ask these questions because there are certain babies who have developed this DAT test positive due to the mother receiving anti-D. So remember that anti-D is also an immunoglobulin against the blood group, and so it will be picked up on this test. So if the infant is DAT positive to only anti-D, the mother received Rh immunoglobulin during pregnancy. You might remember that most of the mothers receive it around 26 to 28 weeks of pregnancy or following any handling like fetal rotation and so on. The mother is known not to be anti-RhD positive before the RhIg. That means she is not sensitized with the previous pregnancy. If any of these are abnormal, then you would consider the baby's DAT as significant. But if all these are true, then you can again assume the baby can return to the normal guidelines. Of course, you would monitor the baby for jaundice. You would do the screening as you would for any other newborn before discharge, but you don't need to be intensively doing it as in this case. If the infant has a hyperbilirubinemia neurotoxicity risk factor, measure the TCB or TSB immediately, and then every 4 hours for 2 times. If it is stable, then you go on to every 12 hours 3 times. So the baby might need phototherapy in these situations, and if the baby develops significant jaundice which needs escalation, you might consider IV immunoglobulin, as we will discuss later in this group. The second section is about supporting breastfeeding, which is a very positive point. The American Academy recommends implementation of maternal care practices that promote comprehensive, evidence-based, family-centered breastfeeding support. So it should be built in as routine, whether your baby goes in for baby friendly certification or not. We should all follow baby friendly practices. Nothing will beat breast milk, and we should do our best to support breastfeeding for all the mothers. The clinician should promote breastfeeding support for all the mothers and breast milk feeding within the first hour after birth, with frequent feeding on demand. Oral supplementation with water or dextrose water should not be provided to prevent hyperbilirubinemia or to decrease the bilirubin concentrations. So this again is a misconception from before, and most of us don't do it anyway because it's not evidence-based. So this is discouraged actively in this guideline. And the promotion of breastfeeding should go hand in hand with not supporting formula feeding because the baby has jaundice, because any introduction of formula feed may actually hamper the mother's effort, and it may affect her psychologically. Her confidence may go down. So most of the babies with jaundice can be managed with just breastfeeding and breast milk. We need to focus on supporting her breastfeeding. You can review my earlier videos on breastfeeding support for the same. The risk factors have been revised in this guideline, and it's not the same as the previous, though it includes the same factors most of the time. The lower gestational age, it's very important. Professor Maisel's study has shown that even being born 37 and 38 weeks is a significant risk for jaundice. So every week that the baby is premature, the risk goes up significantly. And if the baby has any jaundice in the first 24 hours after birth, in this case, don't panic in most of the situations, but it's important to be alert and repeat at regular intervals. Treat according to the chart for that age and look for pathological factors. Here I would like to add that because of the delayed cord clamping becoming universal, jaundice, when you measure it, it's not visible jaundice in most of these babies, but when you measure it, you may start getting it in the phototherapy line. So following the trend should reassure you if there is no other risk factor. The pre-discharge transcutaneous bilirubin or total serum bilirubin approaching the phototherapy threshold is a risk factor. Hemolysis from any cause, if known or suspected, based on a rapid rise of bilirubin. So the rapid rise is defined as more than 0.3 milligram per deciliter per hour in the first 24 hours, or is more than 0.2 milligram per deciliter per hour thereafter. So this part has changed from before. Phototherapy before discharge is a risk factor for further jaundice. If the parent or sibling required phototherapy or exchange transfusion, because the liver maturation and the other factors are usually in line in the family. Of course, the only exception is the breastfeeding gets better as a pregnancy. The number of pregnancies increases. So the risk is mainly in the primary gravida mother who is breastfeeding. Once she has successfully breastfed the baby, the subsequent pregnancies, it gets easier. The family history or genetic ancestry is suggestive of inherited red blood cell disorder, including G6PD. So there is a lot of focus on G6PD deficiency because by the guideline, about 14% of the African American population is at risk of G6PD. And as we live in the Middle East and in Asian countries as well, North India, for example, G6PD is fairly common, same in China and certain populations. So we should be aware of the local incidence as well as the risk associated. If there is a sudden rise in jaundice in a day 3, day 4 baby where it is not expected, the previous screening was normal, you definitely have to think of G6PD deficiency. And remember that during the period of acute hemolysis, your level may not be confirmatory. So if you get a normal result because there are mainly the young RBCs, you may have to repeat it after 3 months if your suspicion was strong. Most of the setups like ours has G6PD in the newborn screening. So if the baby is exclusive breastfeeding with suboptimal intake, so this is defined by the weight gain in the first few days or the weight loss, and we need to do our best to support and encourage early expressing to avoid this rise in jaundice. If there is a scalp hematoma like cephalhematoma or significant bruising, that's a risk factor as well. Down syndrome itself is a risk because of the liver maturation and other factors. The babies usually have polycythemia as well. And if there is a macrosomic infant of diabetic mother, that's a risk as well. So the risk has become more, the definition of risk has become more comprehensive, and it covers most of the risk factors. So identifying the need for treatment, we have to use the total serum bilirubin as a definitive test to guide phototherapy and for escalation of the care decisions, including exchange transfusion. So even though we may use TCB to monitor, to confirm the diagnosis, we have to use the TSB and to treat. The decisions to initiate phototherapy or escalate care are guided by the gestational age, the hour-specific bilirubin, and the presence of risk factors for bilirubin neurotoxicity. So all these factors will play a role in your decision making. The phototherapy charts that we get, which we'll discuss later, include these factors. The presence of hyperbilirubinemia neurotoxicity risk factors lowers the threshold for treatment with phototherapy and the level at which care should be escalated. So now it has been taken care of by giving two different charts for treatment decisions, one for babies with neurotoxicity risk factors and one for babies without neurotoxicity. So this has become clearer. It's important that clinicians use their judgment to determine the presence of neurotoxicity risk factors, including clinical instability or sepsis. So err on the side of caution is what they're trying to say. So you have to be clear. You have to look at all the risk factors. For example, acidosis as a specific risk factor has been removed, but it would be considered as a risk because of the clinical instability. So these are the neurotoxicity risk factors. So the gestational age less than 38 weeks, and this risk increases with the degree of prematurity. Serum albumin less than 3. We will discuss the bilirubin albumin ratio later as well. Isoimmune hemolytic disease, that is a positive direct antiglobulin test. G6PD or other hemolytic conditions. We know that hemolysis may increase the risk of bilirubin neurotoxicity, as the blood breakdown products may compete with albumin binding sites, and so more free bilirubin may be present. So we have to have a lower threshold for treating these babies, and even a lower threshold for exchange transfusion, especially if the baby becomes symptomatic. Sepsis is a risk factor as well, almost for the same reasons, because you cannot predict the course and there may be factors that compete with albumin binding. If the baby has significant clinical instability in the previous 24 hours, so this is a subjective decision and it may be based on birth asphyxia, for example, hypoglycemia, sepsis, acidosis, hypothermia. Any of these may make the baby unstable. If it is a significant instability in the previous 24 hours, you need to treat with caution. So the neurotoxicity risk factors have also been modified from the previous guideline. The approach to measuring albumin is if your bilirubin is going high and you are coming close to treatment level, it's recommended as a workup for measuring, and then when you go to escalation of care, it becomes one of the important criteria as well. So there is recommendation for visual assessment of jaundice in the first 24 hours. If you don't have any risk factors, you won't be measuring the bilirubin in the first 24 hours. So the team members, including the nurses, should be looking for visual indication of jaundice. We know that the visual assessment is not accurate, and the baby should be assessed every 12 hours. This is just to decide which baby would need an earlier TCB or TSB measurement. So once the jaundice is noted, we should measure the bilirubin. We don't need to wait for 24 hours in such babies. So there are some unpredicted rise in bilirubin, and we should be able to pick them up by looking at them with every care, for example. So it should be clear that this visual assessment is an addition and it doesn't replace the need to obtain at least one screening TCB or TSB as described in the next protocol. So the transcutaneous bilirubin levels can be estimated based on measurements of the TCB. The serum bilirubin can be estimated based on the measurement of the transcutaneous bilirubin, and we get the instruments mainly from two manufacturers, even though the others may be present as well. So the Drager and Philips are the ones in US, and there are other companies which make them as well. The devices measure the yellowness of the reflected light transmitted from the skin, and they use an algorithm to predict the TSB level from the objective measurement of the skin color. So it's pre-recorded, and there may be slight differences according to the skin pigmentation level, the prematurity level of the baby, and so on. So we should be careful about exactly taking these readings in certain groups. It's only a predictor. And also the TCB measurements do not directly assess the bilirubin level. So there will be differences in the lab variation of 2.5 to 3 milligrams %. So they are only valid and reliable when used as a screening test to identify infants who need a TSB. And for the same reason, we don't treat on the basis of a TCB. We always need to get a TSB. Of course, you can monitor the trend based on the TCB, and even in the relatively more mature preterm babies in our unit, we use the TCB to act as a trigger to when to do the TSB. Of course, you cannot rely on that. If appropriate follow-up cannot be arranged for an infant, recommended to have outpatient follow-up. Discharge may be delayed. So this is a discussion we have with the family. We have to be clear about explaining the risk factors, and then we take it from there. The TSB is generally within 3 milligrams percent of the TCB among newborn infants with TSB concentrations. So this is a rough rule. It can be plus or minus 3 milligrams. So the TSB should be measured if the transcutaneous bilirubin exceeds or is within 3 milligrams percent of the phototherapy treatment threshold, or if the TCB is over 15 milligrams per deciliter. So you wouldn't risk it. If it goes above 15, it could be fairly high as well, and it may need treatment. So you wouldn't rely on that, even if it's below the treatment level for that age of the baby. If more than one TCB or TSB measure is available, the rate of increase may be used to identify infants at higher risk of subsequent hyperbilirubinemia. So this is what we mean by following the trend. A rapid rate of increase of more than 0.3 milligrams per deciliter in the first hour per hour in the first 24 hours, or more than 0.2 milligrams percent per hour thereafter, is exceptional and suggests hemolysis. In this case, we should do a DAT and also consider closely monitoring and working up the baby, as this is likely to be pathologic like hemolysis. There is a distinction between direct and conjugated jaundice. So many of us are aware of the word direct hyperbilirubinemia and conjugated, but it actually makes a difference in the lab. Conjugated jaundice is actual conjugated bilirubin from the liver conjugation process. Direct bilirubin is only the measure of the bilirubin component, which reacts even before we add the accelerating agent. So that is a lab technique related. So the conjugated bilirubin is always a little lower than the direct bilirubin, because some part of the indirect bilirubin also reacts directly, a small percentage, and that's why the higher the indirect bilirubin, the higher the direct bilirubin as well. So because of this, the direct bilirubin concentrations are higher and more variable than conjugated. However, you have to follow whichever your lab is using. For the breastfed infants who are still jaundiced at 3 to 4 weeks of age, and for formula-fed infants who are still jaundiced at 2 weeks of age, the total and direct reacting or conjugated bilirubin should be measured to identify possible pathologic cholestasis. So there is a small change that for breastfed babies we can be more relaxed and wait till 3 to 4 weeks, provided the baby is thriving, the jaundice isn't worsening. However, in my practice, I tend to do a direct bilirubin in the first week or so if the baby needs a serum bilirubin measurement for any reason. So we have a baseline level, and subsequently, if it is abnormal, we review it. The step what to do next is also changed. So the North American and European Society for Pediatric Gastroenterology, Hepatology and Nutrition defines a direct serum bilirubin more than 1 milligrams percent as abnormal, whereas a cutoff of more than 0.3 has been used for conjugated bilirubin. So if you remember more than 1 for direct bilirubin, it's adequate. The positive predictive value for biliary atresia and other causes of pathologic cholestasis can be greatly improved if you just repeat the measurement. Suppose your measurement is above 1, you don't necessarily need to jump to investigating as a conjugated jaundice. You follow up the measurement after 1 to 2 weeks, and if it is rising, it would be more worrying. If it is coming down, you can reassure. An increase in the direct or conjugated bilirubin suggests the possibility of pathologic cholestasis. Previously, we used to say direct bilirubin of more than 20% of the total. This is no longer regarded as necessary for the diagnosis of cholestasis, again for the same reason that when the indirect bilirubin goes up, the proportion of direct bilirubin goes up as well. So you may be over-diagnosing more patients. In these cases, you would just repeat after a week or so to make sure it's coming down. 1 to 2 weeks is reasonable, but you don't want to exceed a month of age by the time you diagnose pathologic cholestasis, because biliary atresia treatment should be early. It's important to also consider other causes of neonatal direct hyperbilirubinemia other than biliary atresia that would require early treatment. So these include urinary tract infection, isoimmune hemolytic disease, sepsis, and some inborn errors of metabolism. So we shouldn't forget these treatable causes when we are looking for it. Of course, most of the flowcharts that we have for workup of direct conjugated hyperbilirubinemia cover these as well. So the urinary investigations are included, and your DAT, blood group, CBC are included for picking up hemolytic disease, sepsis, and endocrine causes are not mentioned in this, but we should be clear that we don't miss out thyroid and hypopituitarism as well as possible reasons for conjugated jaundice. You can review my short video on sunlight exposure, and it's a similar thing that although direct exposure to sunlight can reduce the TSB concentrations, There are practical difficulties involved in safely exposing the infants, and it may result in a false complacency on the parent's mind, and avoiding sunburn. So we shouldn't be recommending sunlight. There are some families who insist on doing it. In that case also, don't fail to educate them that even though it might be reducing a little, if it is going to the pathologic level, it doesn't do much. So you cannot use sunlight as a treatment option, or even suggest it to the parents to do it. If they do it, to do it safely, you can do it through the glasses, but it shouldn't delay your follow-up appointment that you have planned.